Much for inviting me to talk about something that I'm very passionate about, and I'm very excited to tell you about some newer developments. So my goal with today's presentation is, if I can get it to go. No, it's not moving. Oh, there we go. First of all, I do not have any financial conflicts of interest, and there's no products being discussed that I have any stocks or getting any kickback from. Our learning objectives are to review the normal pathophysiology of hematopoiesis because that will help it make sense to understand the disease process, recognize abnormal hematology disorders, and review of the current clinical practice of hematology disorders. I kind of sectioned them off as developmental hematology, erythrocyte disorders, platelet disorders, leukocyte disorders, thrombosis or clotting, and bleeding disorders. So there's quite a bit of material. So forgive me, but I just felt like it was a good topic to just kind of do a good broad overview because I feel that a lot of you are on the front lines of these issues and you're referring your patients to us. So what are some of the top pediatric hematology consults that we have seen? Iron deficiency anemia is by far the most common consult that we get of all ages. Typically it peaks in the toddler years, and now we're seeing a huge surge in the teenage years for some reason. Neutropenia is another big consult that we get, thrombocytosis, elevated platelet counts, and menorrhagia. Those are probably our top 4 consults. We've also been involved with a lot of COVID-related complications, pulmonary embolism. We've seen coagulopathies, which we typically see a prolonged PT, and on some patients I've even sent a factor 7 level and feel that this is more of an acquired deficiency. They are anemic, thrombocytopenic, and I also get asked about people with these hematology disorders if it's safe for them to get the vaccine. So these are a lot of the questions that we have been fielding over the past few years. So just to start with some developmental hematology, we're going to talk about the newborn period. So just a little reminder, take a step back into hematology. Blood cells first arise in the yolk sac between days 16 and 19 of pregnancy, pretty early. Fetal liver hematopoiesis occurs by week 5 to 6 and lasts through around week 22. And then your bone marrow becomes your hematopoietically active around week 8. And eventually becomes the predominant site of blood cell production. Here's a little diagram showing you yolk sac, primitive hematopoiesis, and that how it goes through the fetal liver and then eventually settles in the bone marrow. Here's another graph just showing you starts in the yolk sac. As that goes down, then it peaks in the liver. As that goes down, then it peaks in the bone marrow. The spleen also does a little bit of hematopoiesis. And then here, you can see why, the vertebral and pelvis have the most amount of bone marrow. This is where we usually get our bone marrow samples from, is in the pelvis area. Early blood cell investigations, erythrocytes were actually the first blood cells identified with the aid of the microscope in the late 1600s, but the colorless white blood cells remained obscured from observation for several hundred years. In 1877, Paul Ehrlich, while a medical student, devised the triacid stain that actually permitted the identification of all hematopoietic precursors and specifically white blood cell. Much of what we have learned has been based on hematopoietic consequences of animal exposure to ionizing radiation. So here's a nice overview of a normal peripheral blood smear. So just to review, your white blood cells can be neutrophils, monocytes, lymphocytes, eosinophils, or basophils. And if you look here, your red blood cells should have a little central pallor and have very plump, red, robust outside. So these are very healthy appearing red blood cells and very healthy, normal appearing white blood cells. Here's a little flow diagram chart of a multipotential hematopoietic stem cell, which is also called a hemocytoblast. It can become either the myeloid progenitor or a lymphoid progenitor. Your myeloid progenitor actually is what differentiates to megakaryocyte, which actually eventually becomes your platelets. So you go from this very large cell with lots of stuff in it to these very tiny pieces or blebs that break off of that. And then you have your erythrocytes, the mast cell, the myeloblast, and then the myeloblast becomes your basophil, neutrophil, eosinophil, monocyte, and macrophages. This is what you're going to see in the peripheral blood. You should not see this in the peripheral blood. That can be a sign of an issue going on in your bone marrow. And then the lymphoid side is even a little bit more streamlined. You have your natural killer cells, and then you have your small lymphocyte, which breaks off to be your T's or your B's. And then the B's break off to be your plasma cell. This is a normal bone marrow aspirate. So this is what an aspirate looks like. This is what a biopsy looks like. So if you remember, these are, you should see a large variety differentiation. So in a bone marrow aspirate, you're going to see all of those cells that I just mentioned as far as the stem cell progenitors, because normally you're not going to see them in the peripheral blood. So these are some really nice, this is a band. And you know, these are very large monocytes here. You see some red blood cells in the background, but you should see like a nice differentiation of a variety of white blood cells. These are usually erythroid precursors. They have this very deep blue stain to their cytoplasm. And normally the red cells, that all gets, as they mature, they lose that. And then over here you have the bone marrow biopsy, which actually is what we use to tell about how cellular the bone marrow is. And these pink areas are called these are little spicules. So if you remember the hematopoiesis, it kind of migrates across the spicule, and that's how it matures. And you should see fat. These are fat lobules in the bone marrow. So when you are drawing a bone marrow sample out, you definitely see like a foaminess to it. And these are all rich cells. I didn't go in a lower power field, but if you went on a lower power, you would see the differentiation that you do over here. So this is more to get an overall view of your cellularity, whereas the bone marrow aspirate actually allows you to look at each characteristic of the precursor cells. And just to quickly review, because this will make sense when I'm talking about anemia, for hemoglobin, you have the alpha chain, the beta chain, gamma goes away, and then there's a little bit of delta. So this will make sense later when we talk about thalassemia, because alpha thalassemia is you got problems in the alpha chain, beta thalassemia is you have problems in the beta chain. Here's just an overview of normal pediatric values of the CBC. So usually at birth, you're very, very high hemoglobins, and you actually have very high MCV. So it's normal to be macrocytic and your hemoglobin hematocrit to be elevated. Then as you mature in age, at actually around 2 months of age, you can have that physiologic nadir. But there's a broad range there, so you can see it anywhere from 2 to 3 months of age. And then as you hit the pubertal years, your hemoglobin actually starts to trend back up. So start high, get low, and then you start to trend back up again around puberty. So what is anemia? Anemia is actually a decrease in the red blood cell mass and or decrease in the hemoglobin concentration. This is definitely our most common abnormality in children. You have to ask yourself, were they born with it or was this acquired? Is this benign or malignant? Is this from blood loss, decreased production, or increased destruction? Hopefully you guys remember what kind of helps you to know this, and it's always the reticulocyte count, because that's commonly not sent or done on an anemic patient, and that can really help you figure out if it's a bone marrow decreased production problem or increased destruction problem. Types of childhood anemia are iron deficiency. This is definitely our most common thing that we see. Pernicious or megaloblastic anemia, not as common, but I have seen it in my 18 years being here. Sickle cell anemia, we have a prevalence of sickle cell anemia in the Baltimore area. Thalassemias are not as common, but we have a couple of beta thalassemia patients. Autoimmune hemolytic anemia has several causes and is fairly common. There's also spherocytosis, Fanconi anemia, Diamond-Blackfein anemia, aplastic anemia, and transient erythroblastopenia of childhood. Tools for the clinical investigator. You definitely want to take a very good prenatal birth history family history, past medical history, and nutritional history whenever you're seeing a patient with anemia. Do a very good review of systems and your physical exam. And typically for the lab evaluation, you want to do a complete blood count looking at your red blood cell indices, a reticulocyte count, a peripheral blood smear. We also typically do LFTs, AST, ALT, Billy, and we do direct and indirect. LDH, iron studies, type and screen, direct Coombs, and hemoglobin electrophoresis, because it really does help to answer a lot of questions. If you're very suspicious that your patient is very, very anemic, then just do the CBC with reticulocyte count and your peripheral smear, because sometimes you don't want to keep, bleeding out your patient because you definitely are definitely can interfere with your, getting what you need, or you can have trouble getting the blood. Actually, we've had kids show up with a hemoglobin of 3, so you just have to be careful. You can learn a lot about what type of anemia and how to do the workup by looking at your MCV. It actually can help point you in the right direction. This is your size of the red blood cells. There's somebody by the name of Cora. Can you please mute yourself?
Cora, can you mute yourself or your computer? Feedback. Can't mute her. Can't mute her. Okay. There we go.
All right. Yes, I think somebody still has their speaker on. Okay. So the MCV are the size of the red blood cells, normocytic, microcytic, or macrocytic. Also, you can look at the mean corpuscular hemoglobin concentration and your red cell distribution width. It just helps to classify your anemia. So this is a nice flow diagram showing you if you have a low hemoglobin level, you confirm the level by looking at your chart, making sure that it actually does meet the parameters of anemia. If you have a low MCV or microcytic anemia, you want to ask, is the anemia mild? What is their history, like the diet history, is it consistent with iron deficiency? And then you want to treat them with iron, retest in a month. Sometimes I do it a little earlier. If their hemoglobin has increased by 1 gram, then its diagnosis is confirmed. You counsel about cow's milk. We usually recommend having less than 16 ounces a day and continue the treatment for an additional, I actually do another 2 months, and try to do a lot of diet counseling. If they're not increasing their hemoglobin, then you want to perform your iron studies, hemoglobin electrophoresis, and don't forget about the lead level. And then if they're, if they're not responding to iron, then you're going to do those things anyway. If the iron deficiency anemia is not responsive to oral iron therapy, then we do suspect like ongoing blood loss. GI bleeding is very common, as well as sometimes we do a urinalysis to also check for microscopic hematuria. There's also anemia of chronic disease that's not going to get better with iron therapy. And you just want to make sure you're on the right track and you want to treat the underlying disease, because usually anemia can be the tip of the iceberg and there's something is more at the base of that. And then thalassemia, or if there's no clear cause, then we are usually helping triage those patients to get them get their anemia fixed. Normocytic anemia, you want to do the retic count. If it's low, then you have to worry about aplastic or a medical disease. Underlying inflammation can also give you some iron indices that are off, but doesn't exactly fit into the microcytic. And then your bone marrow or your abnormal peripheral smear can also suggest that you need to do a bone marrow. Like if you're seeing, is there anything in the bone marrow taking up space so that the body can't make the red blood cells? And then if your reticulocyte count is high, you're going to do your testing for hemolysis, your bilirubin, your LDH, and haptoglobin. If those are positive, then you have to consider enzyme defects of the red blood cells, autoimmune disorders, hemoglobinopathies like sickle cell, or membrane disorders. And then if they're negative, you have to think about blood loss, hypersplenism, or maybe a mix of that type of a picture. And then macrocytic anemia, I tend to worry more about macrocytic anemia, I have to just be honest with you, because I've actually stumbled upon some bone marrow failure syndrome patients this way. I don't really see a lot of folate vitamin B12 deficiencies. I think we've had maybe 2. I've never diagnosed folate deficiency, but it's always on your boards about the goat's milk. So just be careful, because I know there's a lot of parents out there these days using goat milk. So just make sure that their folate isn't depleted. And then the B12 we've seen here a really long time ago. I remember a little baby that had pretty severe pancytopenia, and that child ended up having a B12 deficiency. So it's definitely something that I feel you would pick or get like an indication with the nutritional history, or if they've had a surgery like a short gut or something like that, those kids tend to have a lot of more of nutritional anemias, and our GI folks are all over it. And then the non-megaloblastic anemia, you want to obtain a retic count, and then if your retic count is low, then we do suspect that you either have a bone marrow issue, hypothyroidism, or some other type of chronic disease. If your retic is high, then we're more suspicious that it's hemolysis or hemorrhage. So this is just a nice flow diagram suggesting how to diagnose a child with anemia and if there's abnormalities of other cell lines. So does the child truly have anemia? Yes. Are other cell lines affected? Because there's actually quite a bit of things that you're thinking of when you get these referrals for anemia as a hematologist. So it could be anywhere from, if they have pancytopenia, could be leukemia, could be a myelosuppressive effect of a drug, aplastic anemia, hypersplenism, infection, and then the nutritional deficiency versus anemia and a low platelet count. We have to worry about hemolytic uremic syndrome or TTP, DIC, and Evans syndrome, which is usually a combination of autoimmune hemolytic anemia and thrombocytopenia together. And then if you have anemia but a high platelet count, that's very suspicious for iron deficiency, some type of infection, or post-splenectomy anemia. So a lot of our patients with sickle cell that have had splenectomies, they can run very high platelet counts. And some of my sickle cell patients have even had platelet count over 1 million. And if you have anemia and a high white blood cell count, we worry about infection. And leukemia, actually, you can have a normal, high, or low white blood cell count. So that's when you want to review your blood smear. Sometimes we see blasts, so we know we're dealing with leukemia. Sometimes we see fragmented cells or broken red blood cells. This is more suggestive of a hemolytic uremic syndrome, TTP, or DIC type picture. If you see toxic granulations to your white blood cells or a lot of atypical lymphocytes, then this actually points to some type of infection. And then hypersegmented your neutrophils are B12 or folate deficiency. That I have seen that on a smear. And then Hal-Jolly bodies can actually be seen after post-splenectomy. So basically, all of these things are things that you're considering when you get told somebody has anemia. You're looking, okay, what is the white count? What is the platelet count? And these are all of the things in the back of your mind as a hematologist that you're kind of going through and figuring out how to tailor your physical exam to help answer these questions. So causes of anemia in children. So you have the neonate population, and if they're anemic at birth, this can be a sign of alpha thalassemia, the 3 gene deletion, acute blood loss. We look at ABO incompatibility or RH, so you can have an antibody-mediated hemolysis. We recently had a baby with pyruvate kinase deficiency that presented with a hemoglobin of 5 at birth. So these congenital hemolytic anemias, even if there's no ABO setup or RH setup, you can't forget about those red blood cell enzyme deficiencies like spherocytosis, G6PD, and pyruvate kinase. And then we've seen moms that had parvo B19. Also, the babies can be born with severe anemia. And then macrocytic can be congenital aplasia. So you really worry about, like I said, I tend to worry more about macrocytic anemia just because I've had a couple of patients with bone marrow failure syndromes that have presented that way. Infants and toddlers, iron deficiency anemia is your typical microcytic if they have a concurrent infection. And then there's also thalassemia. So like if you do have the microcytic anemic patient that's not getting better on iron, then we usually, if you haven't done electrophoresis, we do one. And then we see if they possibly could have thalassemia. If your electrophoresis is normal, that points you in the direction of a possible alpha thalassemia because their electrophoresis is normal. Whereas if they have an elevated hemoglobin A2 and F, that can point you in the direction of a beta thalassemia. And then the treatment, the testing for that is alpha globin chain. You look for point mutations, and beta globin chain. You look for point mutations. Normocytic anemia in infants and toddlers. If you notice, acute blood loss is here on all of the normocytic. So you're always worrying about that. Iron deficiency anemia is very common in this age group, especially the milkaholic children that are drinking a gallon of milk in a couple of days. Those kids tend to be very anemic. Sickle cell disease, red blood cell enzyme defects, and if you have an acquired hemolytic anemia or hypersplenism. Also, the age of transient erythroblastopenia of childhood, these children will present with a precipitous drop of their hemoglobin, and they will transiently have no retics. And then what you'll see is later on they will get retics. But this one is usually after a viral illness, and it's usually around like 18 months of age, usually in your clinical vignettes on your questions. And that's typically what we see. Sometimes they do need one transfusion to help their body adjust, and get back up to a normal hemoglobin. But they're very symptomatic. They look very pale. And so we follow them very closely to make sure that their retic count comes back. And if you have macrocytic anemia in that population, you have to worry about B12 or folate deficiency, hypothyroidism, hypersplenism, and congenital aplasia. There's also in the children, older children and adolescents, iron deficiency anemia is another cause, and that's usually with our teenage girls with their menorrhagia, and also we've seen a higher incidence in the cross-country runners. I've noticed that they have more iron deficiency anemia or very low ferritins. So, we've had it's not common, but I have had a couple of sickle cell patients not present until older in life. Very interesting, and we always look into that with the screening. And then macrocytic anemia, again, B12 or folate, and then you have to think about hypothyroidism. The one thing that's not on here that causes macrocytosis is Down syndrome. So Down syndrome kids can have a normal macrocytosis. That is something seen in that population. Oral iron therapy is the preferred treatment. We start ferrous sulfate, 3 to 6 milligrams of elemental iron per kilogram per day. Our biggest problem is people don't like to take their iron. The little kids don't like the taste of it, and the teenagers just don't want to take it. If they do take it, we usually see an improved hemoglobin and reticulocyte count in basically 10 to 14 days. So usually we're seeing them back within 2 weeks to make sure that they are A, taking their iron, and B, that they're absorbing it. Because if they're not absorbing it orally, then we do have the option of giving them an IV iron infusion. The MCV does take a lot longer to normalize and does not quickly normalize like your hemoglobin and retics. And the other take-home point I wanted to make sure I passed on is that even when you get back to the normal hemoglobin level, you still have those deficient red blood cells because the life cycle of a red blood cell is 90 days. So we tend to treat for a total of 3 months to replenish their iron stores. You can decrease your iron supplement, but we don't stop it cold. So they're still getting some form of iron supplement for 3 months. And then we do usually try to reserve blood transfusion for those patients that are symptomatic, or typically if the hemoglobin is less than 5. Here's a smear showing you some hemolysis. So these are what we call schistocytes, or fragmented red blood cells. Here's a teardrop cell. Here's a burr cell. So if you looked at the smear, here's also a target cell. You would be concerned that there could be some hemolysis going on in that patient. So what are some erythrocyte disorders of hemolysis? Thalassemia syndromes, alpha thalassemia, hemoglobin H disease, and beta thalassemia. We do have a patient currently that has hemoglobin E and beta thalassemia disease. There's also gamma thalassemia, sickle cell disease. We do have these unstable hemoglobinopathies where the hemoglobin itself just is not a stable protein. And then there's methemoglobinemia. Thalassemias are inherited autosomal recessive. It's an absence or synthesis of the alpha or beta globin protein needed for hemoglobin production. This leads to hemolytic anemia, hypochromic, microcytic. It ranges from mild asymptomatic anemia to severe hemolytic anemia requiring chronic transfusion therapy or a stem cell transplant. Complications of thalassemia include growth failure, splenomegaly, cholelithiasis, or iron overload. So they don't get the pain episodes that sickle cell patients get, but they have a lot of overlap. And then the diagnosis is made by hemoglobin electrophoresis and then beta globin gene sequencing point mutations if you're concerned that it is a beta thalassemia. So just to review, the alpha is there pretty early. Beta comes later after birth. And then the gamma is the one that goes down. And that's your fetal hemoglobin. And then the delta. So this is just showing you the autosomal recessive inheritance. This also would apply to sickle cell disease and also to thalassemia. So if you have an unaffected carrier father, an unaffected carrier mother, basically I just wanted to show that you have to have two parents that carry because it's autosomal recessive to get the affected child with a 1 in 4 chance of each pregnancy having disease. 2 out of 4 for trait, and then 1 out of 4 doesn't carry it. This is a slide showing you what sickle cells look like on a peripheral blood smear. These are what sickle cells look like. So sickle cell disease is autosomal recessive genetic disorder. It's a hemoglobin S variant of the beta globin gene. It's typically a normocytic anemia. About 8% of African Americans are carriers. 1 in 365 have sickle cell disease. 1 in 16,000 Hispanic Americans are also affected. And 1 out of 13 Black or African American babies are born with sickle cell trait. So it is something that we are raising more awareness. We have had, still to this day, I've had a couple of families that did not know that both parents carried it, and they learned through their child being born with sickle cell disease that they both carried the sickle cell trait. So we still see it today. Here's a nice diagram of the hemoglobin S, the substitution. It's at the position beta 6 position. The glutamine is replaced by valine. So this likes water and this doesn't like water. That's why it gets so rigid and not carry the oxygen well. So this stimulates hemoglobin S to polymerize when it's deoxygenated. And typically what we consider the disease states are hemoglobin SS, hemoglobin SC disease. There's a hemoglobin S beta plus thal where they have a little bit of hemoglobin A present, and hemoglobin S beta 0 thalassemia where they don't make any hemoglobin A. So what is sickle cell disease? What is the basic pathophysiology? Deoxygenated red blood cell or dehydration leads to polymerization of the red blood cell. This distorts into the crescent shaped. The sickle cells are very sticky and inflexible. They only survive about 7 to 10 days in the circulation, where normally the RBC lives about 90 to 120 days. And then there's intravascular hemolytic anemia that results in occlusion of microcirculation and leads to ischemia and chronic end organ damage. So the polymerization affects the red blood cell membrane, leading to abnormal interactions with vascular endothelium. And then adhesions of the red blood cells, platelets, leukocytes, they all go to that area and cause a hypercoagulable state. And then there's a nitric oxide deficiency, which also contributes to the vasculopathy and also increases the tissue ischemia that happens at that capillary exchange level. I have a nice diagram to show this. So if you look here, you have your oxygenated erythrocyte containing your hemoglobin S. It gets deoxygenated and polymerizes. And this is what causes an infarct or lack of blood flow. And this is what leads to your pain episodes, acute chest syndrome, your splenic issues, osteonecrosis, and nephropathy. And then you also have hemolysis where you have destruction of the red blood cell. This leads to functional nitric oxide deficiency, which can contribute to pulmonary hypertension, priapism, leg ulcers, and cerebrovascular disease. So your cerebrovascular disease there's a higher risk of that in a child with a lower hemoglobin and also sleep apnea. Like if they live at lower SATs or if they have lung disease, those children are at the highest risk of having a stroke. And the mean age for stroke and sickle cell is about age 7. And all of these things are contributing to inflammation, increased expression of VCAM1 and other adhesion molecules, and hypercoagulability. So I'm very excited to introduce some newer treatments for sickle cell disease that we actually have started to offer our patients here at University of Maryland. One of them is called Voxelotor or Oxbryta, and basically it does not allow, it actually prevents the polymerization of the sickle cell. So it inhibits the deoxygenated state, and these patients we actually have it approved down to age 4 now. And you can be on the tried and true hydroxyurea that we've been using for years. You can be on both at the same time. So this is one of our newer drugs that has been recently FDA approved down to age 4 for sickle cell disease. And it comes as liquid and it comes as pills. So it's nice that it's as a liquid form as well. Another newer treatment for sickle cell disease is crizanlizumab. All right, try to say that fast 10 times. So basically what this does is this interferes with the binding of P-selectin to L-selectin on the white blood cell. It doesn't allow that because if you remember my diagram showing you how there's inflammation and then the white blood cells go to the area to try to help, but they actually make the pain episode worse or they cause more issues. This actually prevents that vascular occlusion that's happening on the white blood cell level when you have the sickle cell pain episode or acute chest crisis. This is a nice table just showing you guys and comparing. So hydroxyurea we typically offer for 2 years and up. It comes as a pill or liquid once daily. This is definitely the one that we've been using for over 20 years in sickle cell disease, and it's also FDA approved. This one improves your life expectancy. It has definitely been shown to be efficacious in decreasing pain episodes, vaso-occlusive crises, and reduces our transfusion requirements. It has been reported to cause mild hair loss, GI symptoms, and we do recommend stopping it when you become pregnant. L-glutamine is also known as Endari. This is for ages 5 and up. You can be on hydroxyurea with any of these other therapies. This one is given twice daily. It's a powder that you mix in a drink or in a food like applesauce. And then basically it actually supplies the missing amino acid L-glutamine that is deficient in the sickle cell. So this is where this came from. And then the other one that I just mentioned, Oxbryta, has recently been approved, and it comes as tablet or suspension. It's once daily. The nice thing about this one, if you notice, the only one that I need to monitor your blood work is hydroxyurea, which is one of the drawbacks about it. So there's no monitoring of blood with Voxelotor or the newer crizanlizumab, but this has been shown to definitely reduce pain episodes. It can be combined with hydroxyurea or not, and it causes your hemoglobin to increase and decreases hemolysis. You do have to do dose adjustments for interactions with other drugs. So of course we would be involving our pharmaceutical team if there's any other medications. And then it can cause GI symptoms, and we also have to monitor hemoglobin. So if you run a higher hemoglobin, they're not going to recommend it for you because then you worry about hyperviscosity syndrome and you don't want their hemoglobin to go too high. So usually if your hemoglobin's above 10.5, that would be a reason not to offer this. And then crizanlizumab is for 16 and up, and this is an infusion that we give in the clinic, and it's spaced out, and this is actually to help reduce pain episodes. We usually reserve this for patients that are not responding well to hydroxyurea, that are on maximum doses, that you know they're taking it, and we do have a patient on this right now as well. So with this one, you can get an infusion reaction, you can get joint pain or back pain, nausea, and it can cause platelet clumping in samples collected in EDTA. So those are some newer therapies that we are using. So just wanted to mention too, before COVID hit us, we actually were making some headway with gene therapy. So correcting the defective amino acid, and actually they had a successful patient who was on transfusions who could go off transfusions. That was successfully had gene therapy done. I believe it was in Boston. And then they were working on, research was working on an autologous transfusion, meaning you took the stem cells from the or the cord blood from the child corrected the defected amino acid and then reinfused it back into the patient. They didn't get it to that level, but they were doing that in the mouse model. And then we have been doing stem cell transplants. There's allogeneic transplant for sickle cell disease, and currently to date, that is the only cure besides the gene therapy. A matched sibling match would be the best case scenario, meaning the least side effects from the transplant. There's also the ability to do haplo-matched related donor, a parent or sibling as the donor. And we do have a protocol open here at University of Maryland for older patients if they are interested in doing that. And then matched unrelated is the worst type of transplant to do with the sickle cell patients because it seems to be too toxic and they have very severe graft versus host disease. And cord blood, the biggest problem with cord blood is it's very expensive to store and you don't have a backup infusion if the stem cells don't take home and the engraftment fails. So we, even though we do discuss this, I've had very limited people ask about stem cell transplant. And I think it's because they have to get chemotherapy and go through so much, a lot of issues to even think about getting the stem cells infused back in their bone marrow. A lot of people don't realize that. And then when we talk to them about that, they're not interested in doing the stem cell transplant. So I'm very hopeful that our gene therapy actually will have more promise in the future because it's just not ideal for the sickle cell patients to have to go through all that chemotherapy and to ablate their bone marrow. Other causes of hemolytic anemia, we have immune hemolytic anemia. This can be if you have a mom with lupus or if the mom took dapsone. Those types of things can lead to hemolytic anemia in the baby. If they have infections such as CMV, toxoplasmosis, syphilis, or bacterial sepsis, vitamin E deficiency in premature infants, infantile pycnocytosis, and then you have your spherocytosis, elliptocytosis, enzyme abnormalities like G6PD and pyruvate kinase deficiency. Also in the neonate stage, especially, not so much when they're older, but sometimes we see this, polycythemia and hyperviscosity. If you have a hematocrit value of 65% or above, this can be from chronic fetal hypoxia or acute fetal hypoxia, delayed clamping of the umbilical cord, and typically there's a partial exchange transfusion where you are removing blood and either giving them albumin or fluids or something to help offset the blood pressure to get your crit back down. There's also bone marrow failure syndromes. These are very rare and they definitely have different ages of presentation. So I'm just going to mention very quickly, we have had a patient with egg megakaryocytic thrombocytopenia. They don't make platelets, and these children will be thrombocytopenic. And we typically have to, they are transfusion dependent from birth. And they have like gum bleeding, it's very severe. So you can tell that there's something wrong with the platelets. And then diamond blackfan anemia also present very early in life and are transfusion dependent because they have a red cell aplasia and don't make any retex. And then severe congenital neutropenia, these kids tend to present very early, and thrombocytopenia absent radii syndrome also early in life. Fanconi anemia, they typically have constitutional signs, so you're usually getting a genetics consult for those patients because they can have absent thumbs. We actually follow a patient with Fanconi anemia that was transplanted at Sloan Kettering. And then your disc keratosis congenita and your Schwachman-Diamond can be kind of clinically silent until later on in life. So there's a lot of variability in bone marrow failure syndromes. Remember I told you, sometimes you can just pick up on it with macrocytosis and like a mild neutropenia. So when you have that patient with that mild neutropenia, make sure you look at that MCV because that can be a little bit of an inkling that there is something going on like an early bone marrow failure syndrome. When you are suspecting a bone marrow failure syndrome, it's very important to get a peripheral smear and electrophoresis before you give blood cells. Because once you give those transfused red blood cells, I don't know whose hemoglobin or whose red blood cells I would be looking at. So that's, even if you have to give them blood, get that smear and get that electrophoresis, because then we can interpret the data. Some syndromes, like the cytopenias, don't develop until later in life. And then other syndromes, like I said, Diamond Black Fan are transfusion dependent early in life. And many of these syndromes, if you do the electrophoresis, they can actually have an elevated fetal hemoglobin. And it's usually due to the stressed erythropoiesis, and you have an elevated MCV. They may or may not have congenital anomalies present at birth. Here's a nice table showing you the inheritance pattern. If they typically have somatic abnormalities, they all have bone marrow failure syndromes, and they all have a cancer predisposition. So we usually follow these patients lifelong. This is just a nice chart that kind of goes through. This is Fanconi anemia, dyskeratosis congenita, Schwachman-Diamond, Diamond Black Fan, severe congenital neutropenia. This is the amegakaryocytic thrombocytopenia, and then thrombocytopenia absent radii. So if you're dealing with platelet abnormalities or thrombocytopenia, you have to worry about alloimmune versus autoimmune. Alloimmune is caused by the maternal IgG antibodies stimulated by the fetal platelet antigens inherited by the father. And it's you can have possible bleeding in an otherwise healthy term infant. The mother's platelet count actually helps you determine if it's alloimmune versus autoimmune. And so in the alloimmune, the mom's platelet count is normal. Thrombocytopenia in the newborn worsens over the first days of life, and bleeding tendency is worse in the alloimmune when compared to autoimmune. We do use IVIG or steroids. Usually IVIG is the preferred treatment, and sometimes we do have to do a platelet transfusion once you get the IVIG in. And I've not seen cases of intrauterine fetal platelet transfusion, but we definitely follow enough of the intrauterine red cell transfusions here at University of Maryland because of our OB's expertise in that. Here's a nice diagram showing the maternal antibodies and how they develop after fetal circulation of the platelet positive antigen is mixed with mom's blood, and then her antibodies go in to the baby and attack the baby's platelets because of them being positive and hers being negative. Here's a nice flow diagram showing, sort of giving you suggestions on what to do with mild to moderate thrombocytopenia, or if your thrombocytopenia is severe. We really worry about less than 50,000. So usually we are recommending your treatment at this point, especially with alloimmune versus your autoimmune patients, which are typically don't have the bleeding risk, even at the same number, which is kind of odd, but it's what we see in the clinical picture. So autoimmune is typically from maternal ITP. I do feel that the OB team does a very good job of treating the mom, which I think helps to calm things down. Mom's platelet count is low and needs to be treated, and they usually get IVIG. And even though if the baby is born, it usually peaks around, I feel like it's around day 4 to 7 that the platelet count drops, but they tend not to have the bleeding issues, but they still need close follow-up. And if you have a mom that had lupus, you just keep that on your radar, because it can, the antibodies from having lupus can also cross the placenta and cause platelet, blood cell indices difference in the baby. You have to be careful about that as well. So we have an early versus late neonatal thrombocytopenia. So if it's less than 72 hours, we worry about infections, torch, perinatal asphyxia, chronic intrauterine hypoxia like preeclampsia or diabetes, or intrauterine growth retardation. If you have a later onset, you're worried about sepsis or NEC or drug-induced thrombocytopenia. And also don't forget about thrombosis, because if you have a blood clot somewhere, it actually can soak up your platelets and cause a precipitous drop in your platelet count. Liver failure and decreased production of thrombopoietin has also been linked with thrombocytopenia. So usually I ask the NICU team to get a thrombopoietin level if you have a child with a severely low thrombocytopenia, because sometimes it can help you figure out if there's an underlying issue. And typically we treat this with a platelet transfusion, and also make sure you're not dealing with DIC. Here's a nice diagram showing you different platelet abnormalities in the different age groups. So pretty much immune thrombocytopenia purpura is typically seen in the toddler age. Drug-induced can be at any age. Evans syndrome is typically in older children, but we did have a child who was sort of like 7 or 8, but this is typically seen in older kids. Autoimmune lymphoproliferative syndrome. This is ALPS, so they can have these really, really large lymph nodes, and you'll think that they have like leukemia, and they'll have a negative workup, and then you can biopsy one of the lymph nodes, and that's how you diagnose ALPS. Also, systemic lupus. So sometimes we have teenage girls that present with an immune thrombocytopenia, and later on they have the signs and symptoms of lupus. So in my older patients, whether they're male or female, I typically screen an ANA or complement levels because I know that it can be a precursor to an autoimmune disorder. And then vascular malformations like Kasabach-Merritt syndrome, like if you have a child with a very large hemangioma or you're suspicious that they have that, they actually can consume your platelets and your clotting factors. And their blood work will look like DIC. TTP, hemolytic uremic syndrome, and thrombosis. These are all these are all things that can drop your platelet count. And then in the neonates, we just talked about alloimmune and autoimmune thrombocytopenia, infection, and then the pregnancy perinatal factors that can affect the baby's platelet count. So just wanted to mention a newer therapy for immune thrombocytopenia purpura. To diagnose this, we typically are getting a CBC with a differential. We're getting coags. We have had one patient have an intracranial bleed with a very low platelet count. Not common, but we did have to quickly treat her and stabilize her. Viral studies such as EBV, CMV, and HIV, they can present with an isolated thrombocytopenia. And then, the most current recommendations actually say that you don't have to do a bone marrow, but in the past, we typically did a bone marrow because steroids treats a lot of conditions, and you would hate to miss like a leukemia because then you can clear your blasts and not know the type of leukemia. So typically, sometimes we do recommend, if we don't feel like it's a clear diagnosis, we would recommend getting a bone marrow before treating with steroids. If you give them a medication like IVIG, you would not clear your blasts if it was a leukemia in disguise. Rituximab has also been used if you have failed other therapies, and this is it blocks CD20, which is a B cell, and it also it doesn't work right away, but it works in about 2 months. You get 4 doses of rituximab. You actually get, usually for lymphoma, you get 6 doses, but for ITP, you get 4 doses. And then splenectomy, I haven't seen that done in 20 years, but I did have a patient in Charleston, South Carolina that had a splenectomy because he failed all other therapies. And believe it or not, he's still got ITP. So it's nothing is 100%. Even rituximab is only 60% effective. And then the newer one that I wanted to mention is called eltrombopag, Promacta. And this has been added to aplastic anemia treatment. In addition to, we've used it in our chronic ITP patients. So not our frontline therapy for acute ITP. And then I just wanted to say, some hematologists, if you're not bleeding, actually would just observe you, because up to 80% of acute ITP patients actually get better if you do nothing. So there's also a strong argument for just close observation and repeat the CBC in the future. What are some platelet function defects? Bernard-Soulier syndrome is a moderate to severe platelet function defect characterized by mild thrombocytopenia. They usually have giant platelets and a mucosal type of bleeding. Glanzmann thrombocythemia, I actually diagnosed a patient with this recently. They have a deficiency or abnormality of the surface membrane, and this is characterized by purpura, petechiae, bleeding from circumcision. This kid also, he would bleed from his nose, and he would bleed from like a tooth coming in. Just abnormal bleeding, it's not normal. And you have your secretory platelet disorders. You have gray platelet syndrome. If you look at their platelets under electron microscopy, they actually lack the alpha granules. And some of these platelet disorders you can only diagnose by doing electron microscopy and genetic testing. And then you have storage pool defects where the platelets are missing the dense granules. And these alpha granules and dense granules all play in with the clotting process. So they might have a normal platelet count, but they don't work. And here's a diagram. This is a platelet and all the little factories of what's going on in there. You have dense granules, you have pathways, and then it's listing the disease that has an issue with that pathway, or maybe that alpha granules they're missing in gray platelet syndrome, and they actually look very gray. So usually platelets have like a little bit of a purplish discoloration. So if they look more gray, then you would suspect missing alpha granules. And then you have these other giant platelet syndromes. Glanzmann's is the glycoprotein 2B, 3A. That's defective there. So depending on where the defect is in the platelet, would help you to characterize which platelet disorder that you were dealing with. Wiskott-Aldrich syndrome is X-linked. It's associated with an immunodeficiency, eczema, and thrombocytopenia, and they usually have very small platelets. X-linked is just like the Wiskott-Aldrich, but they don't have as severe eczema and immunodeficiency. Thrombocytopenia with predisposition to develop leukemia, autosomal dominant inherited thrombocytopenia with mild bleeding manifestations, and then your A megakaryocyte or hypomegakaryocyte thrombocytopenia has been seen with trisomy 13, 18, and 21, and then Goldenhar-Noonan syndrome, Turner, Gaucher, Bloom, and ALPS. So a lot of times, if I suspect one of these platelet disorders, we are getting genetics involved to help us characterize if they could have one of these genetic syndromes. Thrombocytosis, pretty much, I would say 99% of the time in our world is reactive thrombocytosis. Infection, iron deficiency, these are the most common causes of thrombocytosis. CML, so that we do have a leukemia that can present with a very, very high white count and a very, very high platelet count. And that leukemia itself is very rare in children, but I have seen it. And so you just have to we don't get worried like if your platelet count is 500 and the normal range is to 450. So we tend not to get too excited about the platelet count unless it's over 1 million. But definitely have seen a lot of consults for thrombocytosis. Primary thrombocytosis, meaning just the bone marrow making too many platelets, is very rare in children. Essential thrombocytosis means we don't know why. And then there is a familial form, and we look for mutations in the TPO gene or its receptor CMPL. They actually have a panel that you can order, and you usually get the history. Yeah, my uncle or my parents go donate platelets because their platelet count runs high. Then you have to suspect that they might have a hereditary thrombocytosis or thrombocythemia. This is just a nice diagram showing you what to do if you have a platelet disorder. And as you can see, if you have an abnormal exam pointing to a malignancy, you're going to be getting a bone marrow evaluation. And some of these conditions with platelets, you can only diagnose with a bone marrow. If they have congenital anomalies, then you remember those bone marrow failure syndromes. And don't forget about cyanotic heart disease. So sometimes we get an echo because it just can help point you in the right direction. And then if your platelets are large, you have to worry about those platelet disorders and DiGeorge syndrome. If you have large or normal platelets, then it could be ITP, Evans, drug-induced lupus, TTP, DIC, cyanotic heart disease, and then aplastic anemia, A-megakaryocytic thrombocytopenia, and then congenital bone marrow failure syndromes. Wiskott-Aldrich and X-linked thrombocytopenia have small platelets. So those are just like how you can, this is usually your MPV on your CBC that you look at, is your mean platelet volume. So just to quickly review before we do the white blood cells, and I know I'm running out of time, so I'm just going to quickly go over this. Basically, the take-home point for this is immature immune system at birth. Their neutrophils don't work very well, so they're very high risk of infections. The neonatal neutrophil has a lower level of L-selectin. There's defects in phagocytosis, natural killer cells, serum complement levels until the 3rd trimester. And so usually your complement levels are approximately 50% of their adult levels. And then there's intrinsic immaturity and signaling system of the T cells. So they're very susceptible to enterovirus, herpes, Candida, and toxo. And your B cells rely on functional T cells to help with antigen-producing plasma cells, and cytokine production is generally reduced. So basically the take-home point is your immune system is not fully developed at birth, and it still has a long way to go. So this would quickly go over the transient neutropenia at birth, neutropenia due to accelerated neutrophil destruction. And so you can have, if mom was neutropenic, again, you can have maternal attacking of baby's neutrophils. So, we do see this in the newborn period. And a lot of times what I do is I can send off anti-neutrophil antibodies, not in the newborn period, but when they're older, to help to diagnose an autoimmune neutropenia. And I typically don't have to do a bone marrow in those patients because you've picked up on the antibody attacking the neutrophils. So just to quickly review leukocyte adhesion, because a lot of your deficits with leukocyte disorders can be any one of these binding things so you have the rolling leukocyte that goes to find the abnormality, and then this is what causes the intracellular signaling, firm adhesion, and then the tissue infiltration to go in and clear up the problem. So you can have deficits in any of these areas, and that's what can lead to a lot of your leukocyte disorders. These are just some tables showing you the interleukin tables and where they come from and what they do for you and your immune system. Causes of neutropenia. You have benign chronic neutropenia, constitutional neutropenia. Kostman syndrome is your severe congenital neutropenia. These types of children are presenting with severe pneumonia or osteomyelitis and require IV antibiotics, and this runs in the family. I have treated a patient with that before. Fanconi's anemia, like I said, they typically have outside signs or symptoms. Shwachman-Diamond syndrome, Shediac-Higashi syndrome. All of these things can lead to a decreased production of neutrophils. Neutrophilia, or a high white count, you have to worry about myeloproliferative disorders, acute or chronic infection, leukemoid reactions. Steroids definitely can cause a high white count. Chronic inflammation, tumors, post-splenectomy, cigarette smoking, hypoxia, exercise. There you go. And then eosinophilia, allergic, dermatitis, parasitic infections, drug reactions, GI disorders, hypereosinophilic disorders, and marrow hyperactivity. So if you have a patient who got growth factor shot, you'll see a pretty ramping up of their eosinophils as well. So severe congenital neutropenia, just want to mention that real briefly. These kids, like I said, present very early in life, usually before age 6 months, with severe infections. The cyclic neutropenia is by far the more common one that we see. This is where your neutrophil count can go up and down. Sometimes if they get an infection, it actually goes to normal, but then it might drift back down to less than 500 later on. Shwachman-Diamond is a rare autosomal recessive disorder with variable bone marrow dysfunction. I think of them like a cystic fibrosis patient. They tend to have a lot of overlap with them, but they can have the neutropenia. And then there's glycogen storage 1B, reticular dysgenesis, and osteopetrosis. Sometimes we are asked to do bone marrows on people that these are suspected to help with their diagnosis. So you can have phagocytic cell dysfunction, chronic granulomatous disease, leukocyte adhesion deficiencies, myeloperoxidase deficiencies, and Shediac-Higashi syndrome is a problem with the intracellular packaging functions. These are the ones that have these really large granules if you look at a peripheral smear, and they get recurrent pyogenic infections. So if you have a patient that you're worried has even a normal white count and they just keep getting infections, if you get a culture or you can send off a culture, sometimes it can point you in the right direction as to what white blood cell issue you might be dealing with, because you have catalase positive bacteria and all of these things that can help point in the right direction for the type of infections that the patients get. Treatment, we do use granulocyte colony stimulating factor, GCSF, or GM-CSF, but we typically do a bone marrow test before you do that, because some of those white blood cell disorders, you definitely need to do a bone marrow to look at the stem cell stages. And then in some cases, they also would need a stem cell transplant to overcome the white blood cell issues. Thrombosis, just wanted to put it out there that don't forget about renal vein thrombosis. It's a common sight in the newborn, about 22 to 44% of all thromboses in the neonate. You have to worry about hematuria, palpable flank mass, and thrombocytopenia. Don't forget about the blood clots, because they can cause thrombocytopenia. And then we get a lot of consults about a cerebral sinovenous thrombosis and arterial ischemic strokes that present with seizures. So inherited thrombophilia is out there, and more people are aware of these things. This mutation in the prothrombin gene was actually discovered in 1999, right during my training. And so there's actually a lot of people that have factor V Leiden can also co-inherit the prothrombin gene mutation. So if you have both of those, you're at a very high risk of developing blood clots. This one has not panned out to be so much only in the situation of homocystinuria. And then antithrombin 3 deficiency, protein CNS, typically don't see this condition in children. And antithrombin 3 deficiency is very common in the cardiac kids. Dysfibrinogenemia and homozygous homocystinuria, very rare. And then I get a lot of questions about high factor VIII levels when people are screening these menorrhagia patients. And I definitely see that there is a little bit of a higher factor VIII in those patients, but that alone doesn't worry me because I feel like it's the body responding to the blood loss from the menstrual cycle. So management of neonatal stroke, just wanted to mention very briefly. Hemorrhages, definitely, those have to be dealt with right away, involving a neurosurgeon possibly, making sure your blood cells are to the point where you can have good hemostasis. The arterial ischemic stroke, we do not recommend antithrombotic therapy or Lovenox, but the cerebral venous thrombosis, sometimes we do have to put those patients on Lovenox for a very short course, and then you're keeping close tabs and reevaluating to make sure that it's opening up in that area. So we're usually following these patients with our neurology colleagues. Clinical history of bleeding disorders, just want to make sure you're getting your coags, your blood cells, von Willebrand disorders, platelet disorders, and don't forget about factor 13. Factor 13 is the only factor that is not tested in the clotting cascade of PT, PTT, or fibrinogen. This is that busy slide of coagulation cascade, extrinsic pathway, intrinsic pathway. Don't forget your vitamin K dependent factors are 2, 7, 9, and 10, and protein CNS are also vitamin K dependent. That's what this slide is showing you. Heparin relies on AT3 to be there. So if you have an AT3 deficient patient, so if you have a cardiac kid who's not anticoagulating appropriately, I would suspect AT3 deficiency because heparin relies on AT3 to work. So that's when you have to use some of those other medications like bivalirudin. And then your platelet aggregation, you just want to make sure it relies on glycoprotein 2B and 3A, fibrinogen like collates or intercollects, and that's what stabilizes your clot. So this is where, if you have a problem with your clotting and it's not on this side or the platelets, it could be in your fibrinogen. That's where Amicar comes in because it helps the clot to stay clotted and it prevents the breakdown of fibrinolysis. Congenital factor deficiencies, factor VIII, hemophilia A, it's classified as severe, moderate, or mild, depending on your factor VIII level. 40 to 60% of children with severe hemophilia are asymptomatic as newborns. 50% have a bleed by 1.5 years of age. Intracranial hemorrhage, muscle and mouth bleeding, a hematoma, bleeding from the stump, and following circumcision. So that's typically where you see the bleeding. Factor IX has similar bleeding as factor VIII, so you can't always tell by that. You just have to send off your levels. And afibrinogenemia, dysfibrinogenemia, they can also have a lot of bleeding with circumcision, umbilical cord, soft tissue hemorrhage. Factor V and factor VII deficiency can also have all of these bleeding. So this is where just getting your PT, PTT, and fibrinogen levels can actually help screen for these different congenital factor deficiencies. And then this is just a quick slide about all of the different types of von Willebrand disease, which is the most common bleeding disorder that we see in children. It rarely presents in the newborn stage because the von Willebrand factors are actually, it's an acute phase reactant, so it's increased at birth. So if you send it on the cord blood, it actually can be higher than normal at birth. But we do have to do, it's quite a bit of blood work. So we usually defer the blood work for von Willebrand deficiency until 6 to 12 months of age because it's quite a bit of a lot of blood to send. And then there's congenital factor deficiencies of 10, 11, and 13. I just wanted to mention because we actually recently diagnosed a factor 13 deficiency and they can present with intracranial hemorrhage. So usually if I get a consult about a baby in the NICU that has a hemorrhage, we're sending off a factor 13 level.